39 page.
Hello, good afternoon. Can you all hear me? Yes. Okay, somebody can record, so let others also join. In 2 minutes time I'll start.
Dah ada orang record ke? Dah ada.
So I just go through the revision handout what I have given to you for each of the systems. Today I try to cover GIT and Euro modules. I just go through the slides and then I just discuss some of the facts. If you have any doubts, you can ask me your doubts. So I am ready to clarify you. Today I try to finish GIT and urinary, mainly according to the schedule for tomorrow. And the last week revision also you have attended. Maybe I can focus few of the important focus areas in CVS and respiratory. As much possible I cover today. The rest of the things I will be covering on Thursday. Okay, so Thursday, maybe after my class, it is starting from 10:30 to 12:30. So by Thursday, I try to finish remaining whatever is finished, not finished today. I will do it on Thursday. So tomorrow morning, I am having continuous class, so I just want to finish it by today, so you can have a chance to read, start reading. So I will start now. So the major things today for the GIT, maybe you can focus mainly on the stomach. Stomach, which is very important structure of GIT. So it has got different cells and different secretions. The gastric secretions will contain hydrochloric acid, pepsin, mucus, okay, gastrin, and so on. So, and correspondingly, what are the cells producing the individual secretions? Very important. Okay, so the mechanism of secretions we have covered already. The regulation of secretion of gastric mainly by the gastrin. Okay, so the gastrin produced by the G cells. The G cells are through the vagus nerve that will act on the Na and C cells to produce GRP, to induce the G cells to produce gastrin. Okay, so the gastrin directly it will act on the parietal cells. The parietal cells is the source of secretion of HCl, right? That's a direct pathway. Indirectly, it can activate the enterochromaffin-like cells to produce histamine. So the histamine also will be acting on the parietal cells to produce the gastric acid. Okay. So gastrin either directly acting on the parietal cells or it will act through the enterochromaffin cells to produce histamine so that it can act on the parietal cells to produce gastric acid. Okay, so these are the two important ways by which the gastrin stimulates the HCl secretion. Okay, so this is different mechanisms acting on the parietal cells. Okay, so I just go through the slides, important aspects. So I just highlight. So salivary secretion we covered already. Different secretions produced by different types of cells in the GIT. Okay. So GIP, somatostatin, motilin, peptide, bye. Okay. Okay, so next important structure is the liver. Okay, so the liver we have got many functions. So it is main source for exocrine function and endocrine function. Okay, so the exocrine function is mainly production of the bile and also the bile salts. You know the different types of bile salts, bile pigments, and so on. Okay, so the bile salts and bile pigments, the bile salts mainly involved in fat digestion. Okay, so the exocrine secretions of the liver and also the endocrine functions. So endocrine functions mainly the hormonal functions because it is acting for the site of secretion of insulin like growth factor and also activation of vitamin D because it converts the active form of thyroid hormone T4 to T3 and also it produces angiotensinogen. Okay, so these are the few of the endocrine related functions. So you have to know the what the secretions of the liver, which has got both exocrine and also the endocrine functions. So the bile and bile salts are involved in lipid digestion. Okay, and then pancreas already asked. So maybe the bile salts. So again, I told already. So different types of bile salts. Okay, so how these bile salts are important because you know the primary and secondary bile salts. Secondary bile salts are formed in the intestine, right? So intestine. So the bile acid synthesis, cholic acid, and deoxycholic acid that will be converted into secondary bile acids by intestinal flora by the deoxycholic and also to the dithocholic acid. So you know what is endocrine enterohepatic circulation? Because when it is secreted into the small intestine, it goes through the small intestine. You know, the second part of the duodenum, it opens. Then it goes to the terminal ileum. In the terminal ileum, almost the 95% of the bile salts are reabsorbed. Okay, so only the 5% is excreted in the feces. Only the last one, the 5% is secreted every day by the liver because it cannot secrete the whole 100%. So the 95% is reabsorbed in the terminal ileum and it goes through the circulation through the portal vein. Again, it goes to the liver and then the remaining 5% is synthesized in the liver and then again it is secreted. Okay, so then it is playing important role for the fat digestion and this is called enterohepatic circulation. It is called absorption from the terminal part of the ileum. The bile salts are reabsorbed and it is secreted again from the liver. Okay, so it goes to the liver, then again it is resecreted. So this is the 6 to 8 times a day it will go through the enterohepatic circulation. That's very important. So every day, then if you remove the terminal ileum, so the 95%, more than 90% of bile salts are excreted. So it's not reabsorbed because of intrahepatic circulation is not there. So the bile salt is not available for the fat digestion. So the patient may manifest with the steatorrhea. Okay, the steatorrhea is the manifestation of the removal of terminal part of the distal part of the ileum because the bile salts are not reabsorbed. So they may go for the risk of steatorrhea in the after the post-surgical removal of terminal ileum. Okay, so deglutition is the motility starting from the uh, oral phase, buccal phase, esophageal, pharyngeal phase, and esophageal phase. Then goes to the stomach, then goes to the small intestine. So small intestine and large intestine, we are having the segmentation or mixing movement and also the peristaltic movements. In the small large intestine, we are having the mass movements. The mass movements initiated by gastrocolic reflex or duodenocolic reflex that initiates the defecation. Okay, so the defecation is the expulsion of the feces because of the intrinsic stimulation of the myotic plexus and also the spinal cord reflexes through the afferent and efferent pelvic nerve that increases the contraction of the uh, descending colon, sigmoid colon, and rectum that causes relaxation of internal anal sphincter. Then finally, external anal sphincter is relaxed by the inhibition of pudendal nerve. Additionally, the abdominal muscle contraction that increases intra-abdominal pressure to facilitate the defecation process. Okay, so regarding the absorption, the small intestine is important for absorption of all the components, the carbohydrate, protein, and fat, the digestive product. So the digestion of glucose, the final part of the disaccharides will be taking place in the small intestine. Okay, the small intestine contains the disaccharidases. So that is the one that splits the disaccharides to monosaccharides. The term. So finally, the glucose, galactose, and fructose is reabsorbed in small intestine. Okay, so you can see the disaccharidases, mainly the galactose, the lactase, okay, sucrase, maltase, all these low. Sucrase, maltase, lactase, all these are disaccharidases. So finally, the glucose absorption. Am I audible? Yeah. Okay. So finally, you need to have the disaccharides to final digestion of and absorption of the glucose. Okay, glucose and galactose. Suppose in the children with deficiency of the lactase enzyme, so they cannot digest the milk, right? So because of the deficiency of the disaccharidases, they cannot digest the milk, so they will produce the lactose intolerance. Okay, the lactase is one of the disaccharide. Okay, so the disaccharides will be deficient in this child. Okay, so that's all about the GIT. So any questions? No questions? I'll go for the UR module. So urinary and reproduction. So UR module. So I start with the female reproduction. The female reproduction will be the ovarian cycle and endometrial cycle. Please don't interchange the terms. The ovarian cycle changes happening in the ovary. That is, initial phase is follicular phase, then ovulation. After the ovulation is the luteal phase. The follicular phase is the maturation of the follicle. Primordial, primary, and Graafian follicle is mature follicle. Then the luteal phase is the formation of corpus luteum. Okay, so that is why it is luteal division. So this is very important. So we have the changes in the hormones. So this is the early phase, that is the follicular phase. Then in the middle portion, you are having the ovulation, and later phase is the luteal phase. Similar phase in the endometrial cycle. The proliferative phase is initial phase. Then after the ovulation is the secretory phase. Okay, be careful which phase you are asked. Okay, the proliferative phase is the initial and the secretory phase is the second phase. So what happens in the initial phase? The FSH LH will increase. Then there is a pre-ovulatory increase in FSH and LH. But after the ovulation, that corresponds to the secretory phase of endometrial cycle, FSH and LH will fall. Okay, that means the gonadotropins are FSH and LH. So FSH and LH falls in the secretory phase that is corresponding to the endometrial phase. It is falling. And what happens to the ovarian hormones? Ovarian hormones are estrogen and progesterone. So after the ovulation, that is a secretory phase, you are having increase in the ovarian hormones. The estrogen will increase, and more than that, progesterone also will increase. But at the same time, there is a fall in FSH and LH, but increase in ovarian hormones, estrogen and progesterone. Okay, but initially you are having only the estrogen will increase, but in the later half you have both increase in estrogen and progesterone. So just read the question properly, which phase you are asked, whether it is a proliferative phase or in the secretory phase. So if it is a secretory phase, what happens to the FSH and LH, and what happens to the estrogen and progesterone? So it increases, here both are decreases. So this is the formation of estrogen by the granulosa cells. Even though the theca cells are there, that will be forming the progesterone and then androgens. These androgens will be converted to estrogen by the granulosa cells. Okay, coming to the ovulation. The ovulation, you have two important changes. One is the follicular hyperemia because of prostaglandin, the follicle swelling. Then the other side is the proteolytic enzyme that will cause the dissolution or degeneration of the stigma that will cause the ovulation. So for the ovulation to occur, you need to have the LH surge. Okay, LH surge just before the ovulation. How do you confirm the ovulation? Increase in body temperature and changes in the cervical mucus. So what happens to the cervical mucus? Before the ovulation, the cervical mucus is thin, so the spin-Burkitt test is negative. Okay. So after the spin-Burkitt test is positive. Then after the ovulation, the spin-Burkitt test is negative. Why it is negative? Because the mucus becomes very thick because of the effect of progesterone. So what do you mean by spin-Burkitt negative? There is a loss of fawn leaf pattern. Okay. So before the ovulation, there is a fawn leaf pattern that is positive spin-Burkitt test. But after the ovulation, there is loss of spin-Burkitt test. That is, there is loss of fawn leaf pattern. The mucus becomes very thick, and there is more cellular. Okay, more cellular because of the effect of progesterone. So this is one of the important test for ovulation. Spin-Burkitt test. You have to know the spelling. Okay, spin-Burkitt test. Okay. So loss of fawn leaf pattern, and there is more cellular, more thick cervical mucus that is causing negative uh, spin-Burkitt test because of the effect of progesterone. Finally, after the ovulation, the remains of follicle will form corpus albicans and corpus luteum first. The corpus luteum, later on, it will go for degeneration if there is no fertilization to become corpus albicans. Okay, so endometrial change, follicular phase, and also the endometrial phase that is corresponding to the follicular phase is proliferative phase, and secretory phase is corresponding to luteal phase. Okay, so secretory phase, what happens? So what happens in secretory phase? Anybody?
Thickening of the endometrium.
Yeah, there is thickness of the endometrium. Okay. What happens to the cells? What happens to the stroma? What happens to the blood cells, blood vessel? The endometrium thickness will be increasing too.
The blood vessel become highly coiled.
Yes, tortuous and very much coiled. And the cells become more secretory, right? Like lipids are there, and it is more secretory. What are the secretions? What happens to the stroma? Yes. Anybody? Cytoplasm of stomach cell increases. Okay. How much thickness increases? 5 to 6 mm. Okay. Increase lipid and glycogen. Okay. Glycogen because it's nutrition, isn't it? So it is producing the uterine milk, right? So the uterine milk, suppose in case fertilization occurs, that provides the source of nutrition. Okay, so the three things important: the thickness of the endometrium, and also there is increase in the cellularity and increase in the stromal cells, stromal thickening, and what are the secretions, and what happens to the blood vessels. It becomes more vascular, more tortuous. You can see the tortuosity. Okay, so all these are the secretory phase changes. The proliferation is just try to increase the thickness. Okay, so these are the endometrial changes. You can see this is the gonadal axis. Okay, so gonadal axis how the endometrium, the gonadotrophic hormone will act on the ovarian cells, granulosa theca cells. Ultimately, granulosa cells will produce the estrogen that will have negative feedback inhibition. Correspondingly, in the male, you have the Leydig cells and Sertoli cells. FSH will act on Sertoli cells, and luteinizing hormone LH will act on the Leydig cells. But here you can see the LH will act both on granulosa and theca cells. But granulosa cells will be activated by FSH. But here FSH will act on Sertoli cells and LH will act on L for L, you can remember. So LH will act on the Leydig cells. The Leydig cells will produce the testosterone. So the testosterone will have negative feedback inhibition on hypothalamus and pituitary so that it can inhibit the release of GnRH and also the gonadotropins. But Sertoli cells mainly it is secretory. It produces other secretions also, including the inhibin that will have the short loop negative feedback inhibition on FSH release. Okay. So these are the functions of estrogen. So estrogen is important for the growth, development, pregnancy, parturition, and also for the contraception. Progesterone is important for the early pregnancy. It prevents the uterine contractions, and also it is thermogenic in nature, and the cervical mucus will become thick. Okay, so that is important to produce the positive test for ovulation. Okay, and also it is a component of contraceptive. Okay, testosterone for the male and male child. Okay, relaxin for during parturition. These are the placental hormones. Placental hormones you already know. The first and foremost is HCG for the diagnosis of pregnancy. Okay. I think all these are covered already. So milk injection is mainly by oxytocin, and the mammary gland development and milk secretion is by prolactin. Okay, so milk injection by oxytocin and secretion by prolactin. Okay. So spermatogenesis, you can see the stages of spermatogenesis. So the spermatogonium will become primary spermatocyte. From primary to secondary spermatocyte, you will have the first meiotic division. Okay, and second meiotic division will convert secondary spermatocyte to spermatogonia. From spermiogenesis, after the spermatogonia, I mean spermatids, the spermatids will become the matured sperm. The process is called spermiogenesis. Okay, this is spermatogonium, primary spermatocyte, secondary spermatocyte. In between is first meiotic. After the secondary to spermatid is the second meiotic division. Okay, finally the mature sperm. Usually, the capacitation or the maturation of the sperms will take place in the body of epididymis. Okay, the body of epididymis. So only the maturation will be occurring in the body of epididymis. The seminiferous tubules are involved in spermatogenesis. So after that, the maturation will occur in the epididymis. Okay, these are the process of spermatogenesis. And the secretions of Sertoli cells I mentioned already, the inhibin. Apart from that, MIS, mullerian inhibitory substance, and also the estrogen. They are also produced by Sertoli cells. Okay. So coming to the urinary module. So you can see the juxtaglomerular apparatus. So there are three important cells here. The Lassie cells, in between the glomerular cells. This is the macula densa cells. The macula densa cells are the chemoreceptors because they are present in the early part of the distal convoluted tubule. Okay, the early part of the distal convoluted tubule, the modified tubular epithelial cells will sense the concentration of sodium in the tubular fluid. So they are called the macula densa cells. And the modified endothelial cells of the afferent arteriole, they forms the juxtaglomerular cells. Okay. So in between, you are having the Lassie cells. Okay, the Lassie cells are the mesangial cells. So this is the baroreceptor, and this is the macula densa cells of the chemoreceptors because they identify the concentration of sodium. This is the component of early distal convoluted tubule. Okay, so the juxtaglomerular cells are present in afferent arteriole. So there are different pressures that determines the glomerular filtration. The glomerular filtration, it is similar to the cardiovascular system capillary filtration also, but here we are having the glomerular filtration. The hydrostatic pressure in the plasma and the oncotic pressure is here. The Bowman's capsule pressure is there, but usually Bowman's capsule don't have any oncotic pressure because no protein is filtered here. So the filtration force is only the glomerular hydrostatic pressure, and reabsorption pressure is the Bowman's pressure and also the colloid oncotic pressure in the glomerulus. Okay, so these are the forces. So these are the factors that is affecting the GFR. Okay, the GFR, I think everybody are aware of it. Okay, so the angiotensin 2 will be acting on the efferent arteriole. So that means it increases the resistance, so it causes vasoconstriction, so that it decreases the glomerular filtration. Okay, so it is very important. Okay. Filtration fraction. Filtration fraction is the ratio of GFR to renal plasma flow. Okay, so renal plasma flow. Okay, coming to the tubules. So after the glomerulus, there is a proximal convoluted tubule, and then the loop of Henle. The loop of Henle, descending limb and ascending limb, and thick ascending limb. Then the early part of distal convoluted tubule and the late distal convoluted tubule, and then the collecting tubule and collecting duct. Okay. So what is special about the proximal convoluted tubule? Actually, the 65% more absorption is taking place in the proximal convoluted tubule. So you can see some of the substances are reabsorbed. Okay, so this is important. So because the absorption of water and the sodium is equal, that is why it is maintaining the isosmotic tubular fluid. Some of the substances are reabsorbed, some of the substances are secreted. Okay, the major substances which are reabsorbed are sodium, potassium chloride, bicarbonate, glucose, and amino acids. So these two are completely reabsorbed. Okay, and most of the sodium, that is 60 to 65% of sodium, is reabsorbed. Along with that, there is absorption of water also. Okay, and then the reabsorbed secreted substances are mostly of acids and bases. So hydrogen ion and also many of the organic acids and bases are secreted. So these are the important one. And how the water absorption is different from distal convoluted tubule. Because the proximal convoluted tubule, just now I told, the water is reabsorbed along with the sodium. Okay, so the absorption of water is obligatory, and mainly it is of osmotic diffusion. So along with the sodium, the water is reabsorbed along about 60% or 65% is reabsorbed here, and it is independent of osmolarity. Okay, so independent of osmolarity, how much sodium is absorbed and that much water is reabsorbed. So it does not depend on the plasma osmolarity. Unlikely, The distal convoluted tubule is mainly dependent on plasma osmolarity. If it is more plasma osmolarity, the more reabsorption will take place. So it is mainly determined by the hormone, that is ADH. So it is mainly the facultative reabsorption in the distal convoluted tubule and also the collecting duct. Okay, if there is no ADH also, only 2% is reabsorbed, but mainly it is determined by the ADH, which will go up to 10% of total water reabsorption. So the difference is very important. How much water absorption is occurring in distal and tubule. Okay. So the sodium reabsorption mainly because it is depending on different component. Mainly it is aldosterone dependent in distal convoluted tubule, and it is not hormonal dependent in proximal convoluted tubule. Okay, so this is glucose absorption. I think this question was asked in the EOM. So glucose absorption in proximal convoluted tubule is sodium glucose transporter. Okay, and it is independent of. This is absorption of glucose in proximal convoluted tubule along with co-transporter. Okay. Okay. Loop of Henle, because there are two components, descending limb and ascending limb. Descending limb is more permeable to water. Ascending limb is impermeable to water, whether it is thin or thick. Okay. So thin or thick, it is impermeable to water. So what's special about thick ascending limb? The thick ascending limb, there is a special transporter that is called 1 sodium, 1 potassium, and 2 chloride. Okay, so the special channel that is co-transporter, which is present in the thick ascending limb of Henle, that is 1 sodium, 1 potassium, and 2 chloride pump that will cause reabsorption of sodium and chloride from the tubular lumen into the interstitial fluid. Okay, so you just remember 1 sodium, 1 potassium is present, 2 chloride is present in thick ascending loop of Henle. Okay, distal convoluted tubule, I already mentioned the early part of distal convoluted tubule, you are having the macular densa cells. You can see the picture here. So you can see this is the portion where you have the macular densa. This is the early part of the distal convoluted tubule, which is involved in the chemoreceptor activity. That means it determines the sodium level of the tubular fluid. Okay. And late part of the distal convoluted tubule, there is principal cells and also the intercollected cells. You can see the principal cells will absorb sodium and secrete potassium, and then the intercollected cell again absorb the potassium and secrete the potassium. Meaning that the late part of the distal convoluted tubule will determine the acid-base balance. So if your acidity is more, acidosis is more, that will secrete more of hydrogen ion through the intercollected cells. Okay, so that is only important for distal convoluted tubule, and also it is a site of action of ADH. Okay, the ADH for absorption of water in distal convoluted tubule and also collecting tubule and collecting duct. Okay, so I already mentioned here what is the function of principal cell and intercollected cells. And also the other hormone which is acting on the distal convoluted tubule is ANP. ANP is natriuretic peptide that will cause natriuresis and thereby increases GFR, and which is also very important for the blood pressure control. Okay, if the blood pressure is high, the only hormone secreted is ANP, so that it decreases the absorption of sodium. It increases natriuresis and increases GFR. It reduces blood volume. Okay. So I think ADH I already covered, because ADH is mainly involved in water absorption in distal convoluted tubule as well as in the collecting tubule collecting duct. So other name of ADH is vasopressin. Okay. So if there is no ADH also, the 2% of absorption of water will take place. That is ADH independent absorption. So that's all. So this is maturation reflex. Already we asked maturation reflex. Afferent and efferent is pelvic nerve. The center is S234. And detrusor muscle mainly innervated by the pelvic hypogastric tubes. Okay. Then external sphincter is innervated by pudendal tube. Okay, so that's all about the urinary module. Any questions?
No.
Okay, so today's portion is finished. Maybe I can go through the slides of CVS. If any questions, you can ask. So erythropoiesis, you know the stages already. Pro-erythroblasts are pro-normoblasts, early, intermediate, and late normoblast and reticulocyte. These are the important for erythropoiesis. The iron is important, hemoglobin, and copper will increases the utilization of iron, and cobalt will stimulate the erythropoietin. So, and two important vitamins, folic acid and vitamin B12. In their deficiency, they produce macrocytic anemia, and chronic kidney disease will have the erythropoietin deficiency because it is synthesized both mainly in the kidneys and only 15% from the liver. The calculation already we asked in the UOM. If you are asked for the oxygen carrying capacity, we have to multiply the hemoglobin content by 1.34 ml. So that gives the oxygen carrying capacity. Different types of anemia, iron deficiency will lead to microcytic hypochromic, and then vitamin B12, folic acid, megaloblastic, macrocytic anemia in chronic hemorrhage or acute hemorrhage, it will give the normocytic normochronic chromic anemia. But chronic bleeding will cause iron deficiency anemia. Okay, so I think it is already covered. The response of treatment we'll see by reticulocytosis. Okay, reticulocytosis that will increase in percentage of reticulocytes. So I think MCHC, MCV calculation we asked already in UOM. Okay, so this question also asked the hematocrit increase. So wherever you see increase in the RBC count in polycythemia or in hypoxia, that stimulate the increased RBC count, and also the dehydration, loss of fluid, that will increase the hematocrit. The opposite condition will cause decrease in hematocrit. Hematocrit is percentage of total volume of blood, percentage of RBC in total volume of blood. So any bleeding or anemia that will cause loss of decrease in RBC count, so that you will have decrease in hematocrit, and also overhydration, that is dilutional anemia, that will also will cause the decrease in hematocrit. Okay, so the WBCs, different types of WBCs and platelets or hemostasis and different phases of myocardium. Okay, I think we asked OSPI already. So cardiac muscle usually the pacemaker potential is different from the cardiac muscle potential because cardiac muscle potential will be having the plateau and this one don't have any plateau. Okay, the sympathetic and parasympathetic. So usually the sympathetic is stimulatory to the cardiac muscle. So it increases the excitability, rhythmicity, contractility, and conductivity. And but parasympathetic will have the opposite action. Okay, so opposite it will decreases all these characters. Okay, so it decreases the count, decreases the excitability, decreases the contraction, decreases the speed of conduction. Okay, apart from that, the rhythmicity is determined by the other factors like temperature, pH, hypoxia, or any digitalis like drugs will decreases the rhythmicity. Okay, so these are the four major effects of stimulation and inhibition by sympathetic and parasympathetic respectively. Usually the speed of conduction is fastest in Purkinje cells. Purkinje cells 4 meter per second. Other ventricular muscle, it is 1 meter per second, and it is slowest in the node, SA node and AB node. It is 0.05, okay, 0.05 meter per second. All the muscle fibers, you only 1 meter per second, okay, and fastest is Purkinje fibers. Okay, myocardial infarction, important. So because when there is a myocardial infarction, there are ECG changes. The ECG changes you see is ST elevation and T wave inversion. You can see the T wave inversion and ST Q wave, deep Q wave. Okay, so that is the deep Q wave. Then ST elevation and then the T wave inversion. So you can see the changes in different leads. No need to worry about this, but this is very important. And also the ST segment elevation and depression, both you can see. The ST elevation you can see in myocardial infarction and also in pericarditis. When the level of the isoelectric line is above 2 millimeter, you will call it as ST elevation. Okay, that is mainly determined by TP segment. And ST depression, you will see in ischemia, myocardial ischemia, hypokalemia, and also digitalis. Okay, so all that will cause the causes of ST elevation and ST depression. And what are the changes you will see in myocardial infarction? The deep Q wave, ST elevation, and T wave inversion. So these are the three important cardinal features of myocardial infarction. Okay. So you can see the different heart sounds. The sound 1, S1, S2, S3, and S4. You have to know the characteristics. So the S1 is high frequency, and then the duration is 0.1 to 0.7, and the second one is 0.1 to 0.14. It is shorter. The frequency is highest in second heart sound. Okay, more than first heart sound. Okay, the duration is longer for the first heart sound than the second heart sound. So it is corresponding to the period of the closure of AV valves. And here it is because this is the cause, right? The cause. The duration of the cycle is the ejection period. Okay, so isovolumetric contraction. This is isovolumetric relaxation period. Okay, the third heart sound, usually it is because of the abnormal filling of the ventricles, because of rapid filling of the ventricle by inrush of blood. It is low pitched sound because S3 and S4 is not audible sound. Sometimes S3 can be heard in the children and younger individuals below 40 years, and it is low pitched and frequency also low, and corresponding to the T and P waves. In between T and P wave, you can see the third heart sound. But here you can see the first heart sound coincides with the R wave, and then the second heart sound, it will occur later than the T wave. Okay, so this is also very important. And fourth heart sound, usually it is between the P and Q, that is during the contraction of the atrial muscle, that is atrial systole. The duration is 0.02 to 0.04. It is short duration. Okay. So this table is also very important. You have to know each and everything, and also you have to know the previous slide, changes of myocardial infarction and ST segment, the three important features. Okay. So the splitting of second heart sound will occur during the inspiration, because you can see the only one sound during the normal expiration, because during inspiration, because the right ventricular filling is more, so it takes longer time to close the pulmonary valve. So you can see the splitting of the second heart sound. A2 will be followed by P2, which occurs during the inspiration. During inspiration. So this is called physiological splitting. The pulmonary valve take a longer time to close because of the increased filling of the right ventricle during the inspiration, because the venous return is more during inspiration because of negative intrathoracic pressure. So the explanation you should do. Okay. So the coronary circulation, not much, because already I think we have asked. 250 ml, because more of oxygen extraction of the coronary circulation occurs. So basic blood flow, usually all other tissues receive more blood during systole, but cardiac muscle will receive more blood during diastole. Okay, because during diastole the ventricular pressure gradient is less and there is no compression of the coronary vessels, because during systole the vessels are compressed because of contraction of the myocardium, but it is both are not there during diastole, so blood flow is more during diastole. That is the basic changes. Okay, so this is the simple calculation. So to identify the cardiac output, the cardiac output is the multiplication of stroke volume times the heart rate, and stroke volume is how much ml per beat. Okay, so this is the stroke volume. So if you multiply the stroke volume times the heart rate, you will get the heart rate. That is the cardiac rate, and then the cardiac index is by multiplying the body surface area with the stroke volume. Okay, so that is your cardiac index. Okay, so it is around 3.5 liters per minute. Okay, end systolic and end diastolic volume, that will find out the end diastolic, diastolic filling. The ejection fraction is the formula stroke volume divided by end diastolic volume times the percentage, multiply with the 100. Usually more than 60 is normal. If it is less, that means the left ventricular dysfunction. Left ventricular dysfunction. So ejection fraction is calculated by the dividing the stroke volume by end diastolic volume. So end diastolic volume, if you know end systolic volume and end diastolic volume, you can calculate the stroke volume. Okay, the stroke volume. Okay. So I think any questions? I think everybody are familiar with this. So this is the cause of increased heart sound and increased the heart rate calculation. Between the RR interval, you can calculate the number of small squares. So 1500 divided by number of small squares, you will get the heart rate. Okay. So sinus arrhythmia is normal one. That is the heart rate variation between inspiration and expiration. The inspiration is higher, during expiration it is high and low. Okay. The pulse pressure. What is pulse pressure? Anybody? That's the pressure minus systolic pressure. Come again? Difference between diastolic pressure and systolic pressure. Diastolic first or systolic first? Systolic minus diastolic. Yeah, because systolic pressure is high, maximum pressure. Okay. So the difference between the systolic pressure and diastolic pressure, the systolic is higher pressure, more maximum pressure. So the difference between the two is the pulse pressure. What is the importance? What it indicates? What is the pulse pressure meaning? What it determines? Stroke volume. Yeah, it determines the pulse, stroke volume or the pulse volume. When you palpate the pulse, you can feel the amplitude, right? So that is giving you the idea of the stroke volume. So if you identify by the blood pressure, by identifying the pulse pressure, you can determine the pulse volume. So it indicates or it determines the stroke volume or the pulse volume. So ejection fraction, just now I told, it is the ratio of systolic volume divided by the end diastolic volume times percentage times 100. So if you multiply that one, you will get the ejection fraction. So but the difference between end diastolic and end systolic is your stroke volume. And mean arterial pressure. What is the formula for mean arterial pressure? Diastolic pressure plus pulse pressure. 1/3 of pulse pressure. Yes. How do you identify pulse pressure? You have to identify the difference between systolic pressure and diastolic pressure. That is the pulse pressure. Then you have to add the diastolic pressure 100 plus 1/3 of pulse pressure. You will get the mean arterial pressure. Okay. So the mean arterial pressure, the pressure means millimeters of mercury. Okay. So pulse pressure also the difference, that is millimeters of mercury. If you calculate the heart rate, it is rate per minute. Okay, so these are the unit you should not forget. Ejection fraction is in percentage. Okay, ejection fraction in percentage. So these are the simple things you have to remember. So yeah, this is the formula. The diastolic pressure plus 1/3 of pulse pressure. So the pulse pressure indicates the pulse volume. Okay, the pulse volume or the stroke volume. So these are the determinants of the systolic and diastolic pressure. Okay. Capillary fluid shift. Yeah, capillary fluid shift, you may get it as OSP. Okay, OSP may be the filtration pressure and reabsorption pressure. Maybe I can show you the picture later. So, what is the long-term mechanism and short-term mechanism? The short-term mechanism is the baroreceptor and chemoreceptor. So, any fall increase in the blood pressure will stimulate the carotid sinus or aortic arch that is carried by respectively glossopharyngeal and vagus nerve, so that it can stimulate the sympathetic tone. It will decrease the sympathetic tone, so that it will decreases the contraction of the heart, and also it will cause vasodilatation to bring down the pressure. Suppose if the blood pressure is low, that stimulates the carotid bodies and aortic bodies, which are the chemoreceptors, that is carried by glossopharyngeal and vagus nerve, respectively, to increase the sympathetic stimulation. Sympathetic stimulation will cause vasoconstriction on the blood vessel, and effect on the heart will be increase in the heart rate and cardiac contractility to increase the cardiac output. So it increases the blood pressure. But central chemoreceptors in the medulla, they are more sensitive to carbon dioxide, because carbon dioxide easily will pass through the blood-brain barrier, so that it will form the carbonic acid to form the H plus ion. The H plus ion is very stimulatory to the central chemoreceptor, that is medullary chemoreceptors. But hypoxia is the main stimulus for peripheral chemoreceptors. So ultimately, whatever the chemoreceptor is stimulated, it will increases the sympathetic activity, so that it increases vasoconstriction and increases the contractility of the heart, so that it increases the blood pressure. This is the basic of the short-term regulation by baroreceptors and chemoreceptor. Intermediate is capillary fluid shift. We will discuss later. Then the long-term regulation. So this is important. So the long-term regulation is how the blood pressure is regulated in the long run, many years. So months to years. So if the blood pressure is high, that will be regulated mainly by the kidneys and also by the hormone. What happens in the kidneys? The kidney will decreases the ECF volume by increasing the GFR. Okay, by increasing the GFR. So the GFR will increase the excretion of sodium and water. So mainly the water will be excreted by pressure diuresis, and sodium will be excreted by pressure natriuresis. That means the sodium is heated more. So along with sodium, water also will be excreted. So these two words are very important. You can explain what is the meaning of pressure diuresis and pressure natriuresis. And main hormone that is increasing the sodium excretion is ANP, atrial natriuretic peptide. It is also having the natriuresis effect. So all the three will be decreasing the blood pressure in the long run. Okay, so this is very important. So usually hypotension, so we don't worry about this. So this is very important part. This is a long-term regulation of blood pressure by the kidneys, by pressure diuresis and pressure natriuresis, and also it stimulates the anterior right atrium to produce atrial natriuretic peptide to increase the natriuresis. Okay, that is atrial natriuretic peptide. Okay, so when the blood pressure falls, the opposite comes. ECF volume will be adjusted by reducing the glomerular filtration and also decreasing the excretion of water and sodium. So it increases absorption of sodium and water, facilitated by aldosterone and ADH and angiotensin too. So don't worry about this. This is usually we ask about the hypertension only. So hypertension is increase in blood pressure. This is very important. Okay. Okay, the capillary fluid shift. Capillary fluid shift, this is important because you just see the diagram properly. Arrow mark down means it is filtration. Arrow mark up means it is reabsorption. Okay, so you can add the up arrows and you can add the down arrows. Okay. So down arrows means these two. Up arrows means these two. Okay. Down arrows means it is filtration. Up arrows means reabsorption. So you can add these two values and you can add these two values. For example, this in this diagram, 32 plus 33 is 35 and 2 plus 27 is 29. Okay, so 33 minus 29, how much? 33 minus 29. What's the difference? Are you all with me?
Oh,
Yes. So it is plus 4 or minus 4? Because plus is more, right? Please be interact. Yeah. So that means your filtration is more, right? So your filtration is more. So your filtration pressure is, what are the two filtration pressure? The capillary hydrostatic pressure, I have written here. The capillary hydrostatic pressure and also the interstitial oncotic pressure. So both are favoring the filtration. The reabsorption is, the force is the capillary hydrostatic oncotic pressure and interstitial hydrostatic pressure. This slide is very, very, very important. Okay. So these two are the filtration pressure. These two are the reabsorption pressure. Okay. So you can see. So you have to know how to calculate the values. Down arrows you can add and up arrows you can add and see the difference. So suppose if you are given the value of filtration coefficient. So filtration coefficient, whatever you calculated here is 4, right? Suppose if it is filtration coefficient is 0.5 times 4, that is the volume of urine filtered. So 0.5 times 4 is 2 ml, right? It is 2 ml, yeah. So the volume filtered is 2 ml per minute. That is your final answer. So you can calculate the filtration pressures and also the volume of your volume is filtered using the filtration coefficient. Okay, coming to this, I told you what is the two infiltration force and what is the two reabsorption force. Can you give example for one of these? What is the condition where which increases hydrostatic pressure in the capillary? Hydrostatic pressure is determined by arterial pressure, right? So arterial pressure, so anything that increases the blood pressure, that will increases the hydrostatic pressure. So don't worry about oncotic pressure because oncotic pressure usually in the interstitium will not be very high. Okay. But capillary oncotic pressure is important. So capillary oncotic pressure, which determines the oncotic pressure in the capillary? Which determines oncotic pressure? Plasma? Correct. Plasma protein. Yeah. So plasma protein is the one that determines the oncotic pressure. Suppose if the plasma protein is less, that will cause hypoproteinemia. That will cause the edema formation. So at least one force what determines the pressure you can determine. So the capillary hydrostatic pressure is determined by the blood pressure. So sometimes anything that increases the arterial pressure or the venous pressure will increase the hydrostatic pressure in the capillary. And the oncotic pressure is determined by plasma protein. So the plasma protein, if it is less, that will affect the hyperproteinemia or any kidney disease or any liver disease that will cause hyperproteinemia, right? So in the liver disease, because of decreased protein synthesis, and kidney disease because of increased excretion of protein, both will cause hyperproteinemia, will cause the decrease in oncotic pressure. What determines the filtration coefficient? Filtration coefficient will be affected because of the membrane permeability, right? So the membrane permeability, whichever is affected, example in the burns, okay, in the burns or in any inflammation of the membrane, So that will affect the filtration coefficient. So that is affecting the permeability. So these are the factors that is affecting the filtration. So the capillary hydrostatic pressure is determined by the blood pressure and also the capillary pressure. That means the venous pressure. It will affect. So the oncotic pressure will be determined by the plasma protein. So anything affecting the plasma protein, for example, hyperproteinemia in kidney disease, liver disease will affect the oncotic pressure, and permeability will be affected when that is affecting the filtration coefficient. So in the case of burns or any inflammation, that will affect the filtration coefficient, or any obstruction to the vein or in the lymphatics. The lymphatic obstruction mainly by the filariasis that will block the filtration of the lymph. Okay, so at least one example for each of the factors you can study. Okay, so I have given the examples also here. So at least one or two you can remember. So this slide is also important, and this slide also important. This slide is also important. I have given the explanation here. What happens in cardiac failure? What happens in lymphatic? Finally, the lymph already I mentioned, this is lymphatic obstruction also will lead to edema formation. So these are the important functions of the lymph because it is important for redistribution of fluid, and it supplies the nutrients and removes the waste products, and also it provides the immunity because it's circulation of the lymphocytes. So these are the important facts. So any questions from CVS? Only one more thing I want to tell is the ECG. 1 second. ECG waves and intervals. So just share the slide. Anything you want to ask about the ECG? Yeah. Can you see the slide?
Yes.
Yes. Yeah, okay. So I think everybody are familiar with this slide, right? The P wave, QRS, and T wave, right? So the P wave is atrial depolarization, QRS is ventricular depolarization, and T wave is ventricular repolarization. So next comes the important one, the intervals and segments. So all of you know the intervals meaning it covers one or more waves, but segments will not have any wave, right? For example, PR interval and ST interval. The PR interval is beginning of P2, beginning of QRS complex. It contains the P wave. Okay, it contains the P wave. What is the importance of PR interval? The time taken for the impulse to travel from atrium to ventricle. Okay, the spread of impulse from SA node to AV node. That means the impulse from atrium to ventricle, the time taken. The normal duration is 0.1 to 0.16 seconds. Suppose if it is more than 0.2 seconds, that means there is a delay in conduction that indicates the first degree heart block. Okay, first degree heart block. The PR interval, the beginning of P2, beginning of QRS interval. So this is one of the P interval. Another interval is the ST segment and ST interval. So ST interval and ST segment is only from end of S to beginning of T. Okay. So what is the significance of ST segment? ST segment is the isoelectric line. So the TP segment, the TP segment, TP segment is from the beginning of T to the next beginning of Q wave. So that is the isoelectric line. So if it is elevated or if it is depressed, that means the ST elevation and ST depression. If it is more than 2 millimeters from the baseline isoelectric line, you will call it as ST elevation or ST depression. Okay. So ST interval will beginning of end of Q, end of S wave to the end of T wave. That is the ST interval. Okay. So don't worry about it. What we need is the difference between the ST segment and the intervals and segments, and what is the importance of ST segment and its elevation and depression. I already mentioned what changes will occur in myocardial infarction deep Q wave, ST segment elevation, and inversion of T wave. The three are important changes of myocardial infarction, and also the QT interval and also the TP segment. The TP segment, the TP, the beginning of T wave to the next P wave, that is the baseline, that is isoelectric line. This is also isoelectric line, and this is also isoelectric line. Okay, and PR interval I already mentioned. Beginning of P, beginning of QRS. This is affected in first degree heart block. Okay, the conduction from atrium to ventricle. Okay. So I do cover so far. Okay, so you want me to continue or we'll do the respiratory later? Shall I do respiratory now? Yes, sir. Yeah. So remaining modules I'll cover it tomorrow. No worries. Okay. So I try to close it so that I can see other slides. Endocrine also I cover it later. Okay. GIT close. Endocrine tomorrow I'll come. Okay, respiratory. Okay, respiratory. You know this is a spirogram. Tidal volume. After the tidal volume is the inspiratory reserve volume. After the beginning, below the tidal volume, you will have the expiratory reserve volume. So maximum inspiration to maximum expiration is your vital capacity. So below the expiratory reserve ERV is your residual volume. Okay. So all the definitions, I think all of you remember. Tidal volume is normal volume of air inspired and expired. Okay. Just looking for any picture. Okay. So normal volume of air inspired and expired is the tidal volume. Over the tidal volume, the maximum volume of air inspired at the end of normal inspiration is IRV. And ERV is now maximum volume of air expired at the end of normal expiration is ERV. So the volume of air expired maximally after the maximal inspiration is the vital capacity. Okay, vital capacity. So the volume of air remaining in the lung after maximal expiration is your residual volume. The functional residual capacity is the volume of air inside the lung at the end of normal expiration. That includes ERV plus residual volume. Okay, you can see all these things, how to calculate. So if you are given the vital capacity, if you are given the ERV, tidal volume, and IRV, this is IRV, tidal volume and ERV together, it is the tidal volume, vital capacity. Okay, so suppose if you are given only the vital capacity without ERV, you can calculate also, right? Is it okay? Any questions from me? So you can calculate the vital capacity by adding ERV, tidal volume, IRV, tidal volume, and ERV. Suppose one of it is not given, you have to identify. Okay, you have to identify vital capacity. Okay, so the previous one, other calculations, pulmonary ventilation and minute ventilation by multiplying tidal volume. alveolar ventilation by minus of the dead space, alveolar volume times the respiratory rate. Okay, so this is very important. So, okay, I just move on. Vital capacity is determined by the strength of muscle, lung compliance, and airway resistance. Okay, dead space. So there are two types of dead space, anatomical space and physiological dead space. So anatomical dead space meaning it is extending from the nose to the terminal bronchiole. So it is acting as a conducting zone. Okay, it is acting as a conducting zone because it is no function, it is just conduct the air. There is no gaseous exchange takes place. But physiological dead space includes the alveolar dead space also together with the anatomical dead space. So the alveolar dead space is the one when there is no perfusion. Okay, when there is no perfusion, that means VA by Q. The Q is zero, so ventilation is there, but there is no perfusion. So uh, the volume of air in the non-functioning area is called the alveolar dead space. Okay, so the VA by Q is infinitive. That is physiological dead space. Okay, so I this is very important one. Okay, so you just know what it is. If you don't understand, please ask me anything. Don't hesitate. I'm ready to explain you. So obstructive and restrictive lung diseases. So obstructive and restrictive causes. So what causes obstructive diseases? So asthma, chronic bronchitis, and emphysema. The cause can be anything. So allergens will cause asthma, and smoking may cause both chronic bronchitis and emphysema. Apart from that, alpha-1 antitrypsin deficiency may also cause emphysema. Okay. So restrictive means it can be from interstitial lung disease, COVID also, and extrinsic lung diseases affecting the chest wall deformity or any pleural diseases that prevents the expansion of the lung, or any muscle defect in neuromuscular junction as in polio or any muscle paralysis or muscular dystrophy, all that will come under the neuromuscular or muscular dystrophies. Everything will come the restrictive lung disease. So what is the difference between the obstructive and restrictive? The vital capacity in both are reduced, okay? But here the expiratory flow rate is very much reduced. The FEV1 is very much reduced, okay? FEV1 is very much reduced. Even though the vital capacity is also reduced, FEV1 is very much reduced. So that is why the ratio is very much reduced. So FEV1 is very much reduced and FEV1 is also reduced. Overall, the ratio is reduced. Okay, but the residual volume, functional residual capacity, total lung capacity is increased because the problem is with the expiration. Okay, unlike the restrictive lung disease, vital capacity is less because the expansion is less. So FEV1 is not affected. FEV1 is not affected. So the ratio is also not affected. Sometimes it may be elevated also because the FEV1 is not affected. So the ratio is not much affected. But because the expansion is restricted, the residual volume, FRC, and total lung capacity may be normal or decreased. This is the difference between the obstructive and restrictive lung disease. Okay. Okay. This slide is also important. So normal inspiration and forced inspiration, and normal expiration and forced expiration. So normal inspiration, usually the diaphragm is the muscle of inspiration, but expiration is passive. No need to have any active muscle contraction. But forced inspiration and forced expiration, it is both are active. For forced inspiration, there is involvement of the neck muscles, scalene muscles, sternocleidomastoid muscles are involved apart from diaphragm and external intercostal muscles. Okay, so these muscles involved in inspiration is very important because neck muscles and external intercostal is involved, and muscles of forced expiration is internal intercostal and also the abdominal muscles. The abdominal muscles are oblique muscles and also rectus abdominis. So you should know what are the muscles are involved in forced inspiration and forced expiration. Similarly, I'll come back here for this. This diagram is also important. Okay, I just finished this first. Okay, so dead space and shunt. PA by Q ratio, very important. Just now I mentioned physiological dead space and physiological shunt. Physiological dead space, when there is no perfusion, which occurs in the pulmonary embolism. Okay, in the pulmonary embolism, when there is no blood flow, the wasted ventilation that will come under the category of physiological dead space. The VA by Q ratio is infinitive. Okay, but for any bronchial obstruction, I told you anything that is affecting the narrowing the bronchioles, that is obstructive lung disease like asthma or any chronic bronchitis and emphysema with airflow, the ventilation is not there. So the VA by Q ratio, Q is normal, the shunting is normal. So the VA is reduced, alveolar ventilation is reduced, but perfusion is normal. So the ratio is 0. Okay, the ventilation is not there. So VA by Q is 0. So any obstructive condition you can write. That is the reason for physiological shunt. Okay, physiological shunt. So this is very important slide. The difference between the VA by Q ratio, physiological shunt is 0 and physiological dead space is infinitive. Any causes that is causing the bronchial obstruction you can write for VA by Q ratio shunting, and pulmonary embolism is the reason for physiological dead space. So anatomical dead space is different from physiological dead space. Anatomical dead space is just the conducting zone, and alveolar dead space together it constitute the physiological dead space. Okay, you should know the difference between the two dead spaces. Okay, so the pulmonary respiratory center for normal inspiration, DRG is working, but for forced inspiration, you need to have the VRG also. Okay, so what are the centers involved in forced inspiration? The forced inspiration, DRG plus high neurons of DRG will be playing important role, that is stimulated. So that will stimulate the inspiratory muscles, including the neck muscles, external intercostal muscles, and diaphragm to contract. But for forced expiration, DRG is not involved, only the E neurons of BRG is stimulated. At the same time, these two are inhibited. DRG and I neurons are inhibited. So the external muscles, internal intercostal muscles, and also the abdominal muscles will contract. So this slide is all very okay. So that is involved in forced inspiration and forced expiration. Whether you can write it in a flow chart or in the paragraph, it is okay. So be careful which is in. Okay. Chemoreceptor I already discussed along with the CVS. Okay. So mainly the peripheral chemoreceptors are stimulated for hypoxia, but central chemoreceptors are mainly sensitive for hypercapnia and also decreased pH. Okay. So because they are sensitive to increase in PCO2, and H plus ion is very sensitive to stimulate the central chemoreceptors. Because H plus ion cannot cross the blood-brain barrier, only carbon dioxide can cross the blood-brain barrier, and locally in the brain interstitium it forms H plus ions. Okay, lemmatization already we asked. Okay, so one thing I want to ask is, let us share the PowerPoint. Can you see the PowerPoint?
Yes.
Yeah. So some of the points which is not covered there. Okay. Okay. So the respiratory pathway. So you have different diseases, right? So the cystic fibrosis is the one. Maybe that is affecting the secretions, right? So that will cause the obstruction of the airways. So that will affect the ciliary functions. Okay, that will affect the ciliary functions. So that is also one of the important question. Okay. So what is the genetic defect in cystic fibrosis?
Cystic fibrosis gene.
Some gene, right? What gene mutation occurs in cystic fibrosis?
CFTR.
CFTR. Ah, yes. Yeah. So the chromosome 7 is defective, right? So that is causing the cystic fibrosis. So the cystic fibrosis, the chloride channel is affected. So that will cause the more viscous secretions inside the bronchiole. So that will affect the mucociliary function. Okay. So this is all interrelated things. Okay. What else I want to ask you? Okay, epithelial cells, Clara cells will be involved in progenitor function, macrophages. Okay, macrophages for the alveolar macrophages. Yeah, forced breathing, I already mentioned. Okay, ventilation perfusion, I think I have explained already. All of you are okay. So ventilation perfusion, dead space is infinitive and shunt is 0. Okay, because alveolar ventilation is 0. Here the perfusion Q is 0. Okay. The types of hypoxia, circulatory hypoxia, anemic hypoxia, and histotoxic hypoxia. One of the anemic hypoxia is decreased in RBC count, that is in anemia. Also, in a condition where you have the carbon monoxide poisoning, also will affect the oxygen carrying capacity. Why? Means carbon monoxide will have the more affinity to bind with the hemoglobin. So that will lead to the red color of the hemoglobin, that is called cherry red color of the hemoglobin, right? So that is the diagnostic of the carbon monoxide poisoning. So the carbon monoxide poisoning is one of the cause for the anemic hypoxia because it has got more affinity to bind with the hemoglobin. Okay, so when there is more binding of carbon monoxide, so that is a cherry red. You can see here the cherry red color. That is very dangerous. Okay, so when 70 to 80% of hemoglobin binds with the carboxyhemoglobin, carbon monoxide. Okay, that is causing carboxyhemoglobin. I think I have covered obstructive, restrictive, and also the calculation, and also what is the difference between the dead space. This to calculate how to calculate the different tidal one, IRV and ER. Yes, I think we can stop here. It is too much now. So remaining modules, I do cover it on Thursday. Okay. If you have any questions, also you can clarify me. You can ask me on the day. Shall we end the session now? Yes. Okay. Don't worry. I think just focus what we have discussed now. If I'm just focusing the important points, so you will be based on that. You can be asked. You can answer. Okay. So mostly I cover the major components. Can stop recording. Okay. So mainly I do cover the portions of MEQ part and also the ASPI part. Rest of the things I'm just touching here and go. So those things may be covered under the EFQ and also MCQ part. Okay, so Whatever I do cover the major portions that may be covered in your MEQ and also in OSPI portions. Okay. You know what are the things I discussed for the OSPI also. So this is more than enough for you. Don't worry. So be relaxed. To revise what from the maximum of tutorial notes and little bit here and there from the last notes. If you cover entirely the tutorial, maximum you will be covering. Okay. I wish you all the best. Do practice today for your clinical skill and also your dissection, anatomy dissection. For the clinical skills, maybe you have 2, 3 only maximum hands-on. Intramuscular injection, NG tubing, and catheter insertion.
Cathetering.
What else? Any mannequin dependent,
Cathetering.
right? CPR we don't ask actually.
CPR we don't ask.
CPR actually we don't ask for year 2. Maybe these 3 are the important clinical skill. Maybe you can practice well on the three. Anyone you may be getting. Okay. One from communication skill will come. Okay, the communication skill, either the information gathering or information giving. Okay, so maybe you can be asked. Suppose if you are given the scenario, first component is you have to introduce and you can ask the details of the patient and get the consent. Then you have to ask the details of the thing, or if you may be giving the information like you can explore any of the investigation report or any of the disease. You need to give the information to the patient. Then the patient may be asking some questions. You have to answer the patient consents, right? So the patient consents. So the eyes you should not forget. Okay, patient's consents and also the expectations and also the patient information. Okay, so the information about the disease. So these are the 3 things you need to cover. And finally, please don't forget to give the summary. Okay, and also the safety netting and also thank you. So each of the component will carry the mark. Okay, summary is the one, all the positive points you cover, and then safety netting. Finally, if you want to say anything, then you can ask the patient. If you want to say anything, the last you can ask. So all the components will carry the marks. Okay. Uh, any questions? I think enough for you. I wish you all the best. Remaining modules I will cover on Thursday. No worries. Thank you.
Thank you, Prof.
Thank you. Okay.
Okay.
Thank you, Prof. Okay.
Thank you.
Thank you, Prof. Okay.